Hello, everyone. Thank you so much for joining. I am super excited for today's webinar, as today is the first webinar that we have together with the Gay Men of Color Fellowship and the HIV Prevention Action Coalition, HPAC. And I am ready and excited to have this conversation because it is a timely conversation about PrEP funding, PrEP policy, and as we see how the HIV field has changed in terms of policy, funding, we have seen a lot of need, but also this opens the possibility for more meaningful engagement of the community, really find ways to tackle these challenges that we have seen in the field. So that's why today we have a set of experts. We have Nick Armstrong from the ACE Institute, and we have Mike Ware from NASDAQ, and we also have Tevin Matthew and Dexter Davis from the Gay Men's Scholar Fellowship. And Nick and Mike will be presenting, kind of giving us an overview of the state of PrEP policy and funding. And then we are going to be engaging in a conversation with community members from the fellowship and everyone in the panel, really, and also for anyone in the audience. And before that, I want to say I want to do the shameless plug that we always start with in this webinars is that if you need information about HIV treatment, prevention, how to engage community members, make sure that you go to the CDC's Let's Stop HIV Together website. There you can find more information that you can post on social media. It's social media ready. It has captions that you may use. And they also have really cool services locator where you can put your zip code and then you can find services there. And you can also order at home self-test. So if that is something, a modality that you would prefer, please make sure that you go to the link. I will post it in the chat so that you can either visit to receive a home test or the Let's Stop HIV Together camp. So now, going back to the webinar, again, thank you so much, Nick, Mike, Tevin, Dexter. Before we go into the presentation, let's do a quick round of introductions so the audience knows who you are, and then we can jump into the presentation. Let's start with Nick.
Hi, everyone. Nick Armstrong, use he, him pronouns. I'm the manager of advocacy and government affairs at the AIDS Institute. Good to see everyone.
Mike.
Hello, everyone. Mike Weir. I'm a director on NASDAQ's Policy and Legislative Affairs team. I use he, him. It's good to be here with y'all today.
Let's go with Tevin.
Hi, everyone. My name is Tevin Matthew, and I use he, him pronouns, and I am a medical case management coordinator at Nashville Cares. So thank you all for joining us.
And Dexter.
Good afternoon, everyone. My name is Dexter Davis. I am one of the fellows, and I am a case manager as well as public health coordinator with the Urban League of Hampton Roads. Thank you for having me.
Perfect. Thank you all so much. And now I will yield the floor to Nick and Mike.
Great. Can you see our slides?
Yes. Yes, we can.
Okay. Hi, everyone. And thanks again for the invite to present. Again, my name is Nick Armstrong. I'm with the AIDS Institute. So Mike and I will give a quick sort of state of play of PrEP policy in the United States. We're going to focus on, different payers for PrEP, some issues we've been seeing with coverage of PrEP as a preventive service, as well as different funding streams. If you have any questions, I think we're going to have some question time at the end, but I think we're going to start with Mike, so I'll pass it over to him.
Thanks, Nick. You can go ahead to the next slide. Awesome. So I'm just going to start off with a quick overview of PrEP. I think the majority of us probably know what PrEP is, but how the available options have evolved since PrEP was initially approved by the FDA. So PrEP, pre-exposure prophylaxis, is the use of antiretroviral medications by a person who does not have HIV to prevent acquiring HIV. When taken as prescribed, PrEP reduces the risk of acquiring HIV through sex by up to 99%. So our first approved medication for PrEP was Truvada, which was back in July of 2012. And it is now available generically, which has significantly lowered the medication costs that we see. It is approved for people of all genders who may acquire HIV through sex and or injection drug use. Our next PrEP modality came about in 2019, and that was Descovy. And Descovy is approved to prevent sexual acquisition of HIV, except for people whose potential exposure is through receptive vaginal sex. And so that limitation is important because that population was not included in the original efficacy study. The first long-acting injectable option, Apretude, was approved by the FDA in 2021. And after the initial loading doses, it is administered every 2 months. And this provided an important alternative for individuals who prefer to not take a pill every day or have difficulty maintaining a daily adherence. Our next option came in 2025 with Yes2Go, and it's administered every 6 months. And this was a very, along with Apretude, but Yes2Go also was a major development because it reduces the number of PrEP doses from either those daily pills or the 6 injections that are required for Apretude to just 2 injection visits per year. And so these choices are important because there is no single PrEP option that works best for everyone. Daily pills may offer convenience and or privacy for one person, while the long-acting injections may work better for someone that's concerned about adherence, stigma, or storing medication. The broader policy question is no longer whether PrEP works. We know that it does work. And the question that we are often tasked with is whether people can obtain the option that is clinically appropriate for them, as well as sustainable for them. Next slide, please. So this is a study from Emory University, AidesView put it out, and I'll put the link in once I get done. But the slide demonstrates why expanding PrEP use matters at the population level. So between 2012 and 2022, states that had the highest average PrEP coverage experienced a 38% decrease in new HIV diagnoses. States with the lowest coverage experienced a 27% increase in their HIV diagnoses. And this is an association rather than proof that PrEP alone caused every change, but it does provide some strong real-world evidence that higher PrEP utilization is connected to fewer HIV diagnoses. However, that national growth in PrEP use masks substantial inequities in who is receiving it. So the latest AgeView data shows that Black people account for 39% of new HIV diagnoses in 2024, but only 15% of PrEP users in 2025. And for Hispanic and or Latino people, they accounted for 34% of diagnoses in 2024, but only 18% of PrEP users. And that pattern is reversed for white people. They accounted for 21% of new diagnoses, but 62% of PrEP users. So another way of measuring this disparity is the PrEP to need ratio, which compares the number of PrEP users with the number of new HIV diagnoses in the same population. And so in 2025, there were approximately 6.5 Black PrEP users for every new diagnosis among Black people, and 8.6 for Hispanic or Latino PrEP users for every new diagnoses. Among white people, that ratio was 45-1. So there is also a substantial gender disparity that we see in the U.S. Women accounted for 20% of new HIV diagnoses in 2024, but only 10% of PrEP users in 2025. And the PrEP use rate among men was 9 times that of among women. And so these numbers show that PrEP utilization does not align with the HIV prevention need. And the communities that are most affected by HIV are not receiving a proportionate share of PrEP. And that gap should not be interpreted as a lack of interest or personal responsibility. It truly reflects structural barriers, whether that's unequal insurance coverage, provider biases, low rates of PrEP discussion and routine care, stigma, medical mistrust, as well as limited access to culturally responsive providers. So although overall PrEP use has been growing in the U.S., equitable utilization remains one of the central unfinished policy challenges that we often focus on, both within our work and within our coalition work. Next slide, please. So this is looking at some of the structural barriers, like I just mentioned, but particularly looking at insurance coverage. And so this slide separates people into three broad coverage groups: the uninsured, the underinsured, and the insured. And so each group faces a different version of the access problem. For someone who is uninsured, the challenge is not just paying for the medication, it's also the HIV testing that's required before initiation, as well as the ongoing monitoring that is required. Depending on the regimen, a patient may need kidney function tests, hepatitis testing, STI screening, as well as clinical visits and injection administration services. And generic oral PrEP can be inexpensive, but the complete package of visits and laboratory services can still be unaffordable. For those who are underinsured, a high deductible or co-insurance can create similar problems. Their insurance card may suggest that they have coverage, but they still may face costs before the plan begins paying. So coverage may also be fragmented. The medication is covered through the pharmacy benefit, while labs, the visits, and the actual injection are billed through the medical benefit. And even those individuals that have comprehensive insurance, they can receive improper bills when services are coded incorrectly or claims for the medication, labs, and visits are processed separately. But public coverage does help, but it's not entirely uniform across the country. So most Medicaid programs cover PrEP. Medicaid expansion plans must cover USPSTF grade A and B preventative services without cost sharing, including those recommended for PrEP and essential supporting services. And Nick will cover a little bit more around what USPSTF and then why we do so much focusing on it. Traditional Medicaid programs have more state-level variation in the benefits that they're able to offer, the formularies, as well as the cost sharing that their enrollees see. Access can also be affected by preferred drug lists, prior authorizations, limited provider networks, and whether an injectable medication is processed through the medical benefit or the pharmacy benefit. Medicare coverage changed significantly in 2024, September 2024, and Medicare Part B now covers all FDA-approved oral and injectable PrEP without deductibles, co-payments, or co-insurance. The benefit also includes the injection administration, up to 8 counseling visits, and 8 HIV screenings every 12 months, plus 1 hepatitis B screening. This is an important improvement, but patients still need a provider or a pharmacy that understands the Part B benefit, since most drugs are in the Part D benefit, and that they are prepared to bill it correctly. So the central point is really that technical coverage does not always equal practical access. So a person needs the medication, the supporting services, an accessible provider, as well as a payment system that works as intended. Next slide. So how can PrEP assistance programs bridge that gap? And so this is where state and local PrEP assistance programs play an important role. I do think it's important to highlight the distinction between a PrEP assistance program and an AIDS drug assistance program, or ADAP. So ADAPs are there to help individuals who are already living with HIV obtain their antiretroviral medications, while PrEP assistance programs support individuals who are HIV negative but need access to antiretroviral medications for prevention. So, and I'll put a link in when I finish that will go over all the actual jurisdictions and what they provide. But depending on the jurisdiction, a PrEP assistance program may pay for medication, it may do the labs, the clinical visits, it may even also offer some sort of assistance with insurance cost sharing. Some also provide telehealth services, pharmacy partnerships, PrEP navigation. They may offer PEP or post-exposure prophylaxis, as well as doxy-PEP services. But these programs are often intended to fill gaps. They are not a substitute for comprehensive insurance coverage. Medicaid expansion really does help illustrate this point. So there was a recent state level study that found that Medicaid expansion was associated with an approximately 19% increase in the PrEP utilization rate within that jurisdiction and a 40% improvement in the PrEP to need ratio. So earlier research has also found that Medicaid expansion produced nearly 8 additional PrEP users per 100,000 residents each year, where they especially saw large gains among adults 25 to 34. And so the mechanism is somewhat straightforward. Medicaid covers the medication, the testing, the visits, and ongoing monitoring as part of a substantial benefit. When more low-income adults gain continuous coverage, more people can start and remain on PrEP, and that allows the PrEP assistance programs to focus their often limited resources on people who remain uninsured or face gaps that Medicaid does not resolve. But as many of us all of us may be aware, beginning in January of 2027, certain adults will be required to document work reporting requirements that were passed last year. And so while there are exemptions, states must still build systems to determine who is subject to the requirement and verify the compliance. And so if compliance or an exemption cannot be verified, a person may be denied coverage or disenrolled. And so for PrEP access, the risk is not limited to people who are not working. People who are working have unstable schedules or qualify for an exemption may still experience coverage interruptions because of reporting or verification problems. So when someone loses their Medicaid, the need for HIV prevention services does not disappear. Instead, they actually may shift to a PrEP assistance program, to a safety net clinic, or to their own individual self to try and access PrEP. Next slide, please. So this chart shows why insurance coverage matters to PrEP assistance programs at a jurisdictional level. So NASDAD, we sent out a request for information to the jurisdictional health departments, and we released a directory that identified 18 programs across 17 jurisdictions. 14 of those programs covered the laboratory costs for uninsured clients, 13 covered the clinical visits, 13 covered navigation. 11 offered telehealth support, but only 9 directly covered medication costs for uninsured clients, and only 3 provided insurance premium assistance. And the variation is important. A PrEP assistance program may cover lab services and navigation, but rely on Medicaid, private insurance, or a manufacturer program to pay for the medication. These programs are therefore designed to fill particular gaps, but not replace comprehensive insurance that we see within Medicare, Medicaid, and private insurance. And this is why Medicaid policies have consequences also for PrEP assistance programs. Medicaid expansion, like I mentioned earlier, has been associated with greater PrEP utilization because it provides a more stable path to medication, testing, and clinical care, and often wraparound services that an individual may actually rely upon to be and remain adherent to PrEP. So if work reporting requirements or other eligibility changes cause people to lose Medicaid, their need, again, for PrEP does not disappear. And because most PrEP assistance programs have fixed budgets and or limited benefit packages, they may not be able to absorb a large increase in demand, particularly an increase that we see because of these proposed or not proposed, these changes that are coming down within Medicaid programs. And so the results could be narrower eligibility for PrEP assistance programs. They could offer fewer covered services, or there could be a greater reliance on manufacturer assistance programs. So federal prevention funding, which Nick is going to talk a little bit more about, also supports many of the testing, navigation, as well as the community services that are keeping these programs whole and surrounding these programs. And so I think the key point really from my point is that PrEP assistance programs are essential, but they work best as a complement to stable Medicaid coverage and a strong public health infrastructure, and not a substitute for one or the either. one or the other. And so with that, I'll hand it over to Nick, who's going to cover the private insurance, the federal funding, and the broader legislative landscape.
Thanks, Mike. So before I go into details about PrEP and private insurance coverage, wanted to talk quickly about the U.S. Preventive Services Task Force, which Mike mentioned briefly, because it really does dictate how PrEP is covered in private insurance. So backing up a little bit, what is the USPSTF? This is a task force of independent volunteer national experts on preventive services, on medicine in general. And what they do is they're a pretty deliberative body where they look at different preventive services. So such as medication that prevents certain diseases. They review the evidence and they do a cost benefit analysis. So they see, if we provide this service, is there a substantial benefit for the cost of it with preventing, disease or preventing, negative health outcomes. And they do grade these things on different scales. So you can see on the right of the screen, they have A, B, gradings. That means A is a substantial benefit, B is a moderate benefit, C, D, and I. Means they have an insufficient evidence. So how this process works is you can request a review from the USPSTF, or they might do it themselves. It is a multi-year review process where they look at all the different literature and all the different clinical studies, see if there is a actual benefit, and they make those recommendations. And then, what is a grade A mean in practice? So in a clinician's office, a grade A has means that they will provide and offer this preventive services to people who might benefit from it. And when we talk about the practical implications for coverage under the Affordable Care Act, almost all private insurance plans and Medicaid expansion plans have to cover a medication with a grade A without any copays or deductibles. So you can see on the right, there are some, some different examples of grade A services. So blood pressure screening, HIV screening has a grade A recommendation, tobacco cessation counseling, and the actual medications. So all these have to be covered by private insurance. So that's ACA plans, that's your private insurance from your employer without any out-of-pocket cost for the patient. PrEP does have a grade A recommendation from USPSTF. So in 2019, the USPSTF had released their grade A recommendation for PrEP, meaning that the actual medication had to be covered without any cost sharing. Back in 2019, this was when we didn't have generic alternatives for Truvada. Truvada was the only medication at that time that was available. So some of the folks had high copays for actually picking up the prescription. So in 2021 was that medication, the mandatory coverage actually went into effect. There was also in 2024 further federal clarification that HHS, the Department of Labor, and Treasury said that they must include all forms of PrEP, and also you have to cover all the related ancillary services. So all the labs, the screenings. If you go to a provider just for PrEP, that there should be no cost for that actual office visit and the counseling. So if you wanted to start PrEP and you want to maintain PrEP, anything that's specifically on PrEP, if you are in a private insurance, should be covered without any cost sharing. Wanted to briefly touch on a report that the AIDS Institute put out a couple of months ago. This has this is our third year of doing this report. It came out of stories we've been hearing about people with private insurance, either through ACA or from their employers, where even though PrEP has a grade A and it has all those regulations, they were still being charged for out-of-pocket costs, whether that was the medications, they were being charged copays for their labs, which can be fairly expensive. There was a lot of complaints about insurance companies not actually complying with the regulations. So this coverage is still not clear. We're still seeing complexity and confusion about what people know. A lot of people who use PrEP might actually not know that if they are covered in private insurance, they should have no cost sharing associated with it. It's hard to figure out what plans are and are not covering. The coding behind PrEP, I know it sounds like there's some folks who work on the medical side of PrEP in the audience, and those bills and those codes between the provider and the insurance company are also fairly complex. So what we did in our report, I'll make sure I have the link in the chat, is we reviewed 310 plans. So all of the plans that are available in the ACA marketplaces in all 50 states and DC. We can't actually look at the insurance documents of private plans that you have in your, provided by your employer, but all the plans available in the ACA marketplace are available, and all those documents are public. So what we did is we went through these plan documents, we looked at the formularies, and we had a lot of different, research questions about how they were stating how they cover PrEP. Do they state in the formulary that it's available without any cost sharing? Do they list, the plans as being a free preventive service? Do they list PrEP in their preventive services list? So, if you want to look at our report, you can look at some of the specific questions here. But overall, these were our findings for this year. You can see that a lot of plans list at least one PrEP medication without cost sharing, so 94%. But then when you're looking at, are all versions of daily oral PrEP, so Truvada, generic Truvada, Descovy, is that listed in their formulary without cost sharing? That goes down. Is one long-acting injectable PrEP listed without cost sharing? About half of the plans list that. Are all versions of PrEP, that's including daily oral and long-acting injectable, listed without cost sharing? Only 16% of plans do that. And then when you look at those ancillary services, 69% of the plans listed PrEP as a preventive service, but 34% listed those ancillary services without any cost sharing, and then only about 30% listed those labs. We went through and gave plans each a grade, and you can see a lot of plans got really bad grades. So only 12 plans had everything listed correctly in their plan documents. I can tell you that 11 of those plans were from one insurance provider that offers plans in 11 different states. So almost all of those A's were for one insurance provider, and you can see 60% of those plans we gave an F grade. If you look in our report, it goes through the plans and the appendix. You can look into your state and see what happens there. And then long-acting injectable is a big gap we saw in our analysis. One of the issues with long-acting injectables is a lot of it is covered as a medical benefit and not a pharmacy benefit. So it might not be correctly listed in their formularies because it's covered as a medical benefit and not something that a pharmacist would provide. It is something that a person's doctor would provide in their office visit. So it's a little bit hard to figure out how these plans are covering long-acting injectable PrEP. And then just overall, we find that inconsistent the describing and this information that insurance companies provide can really impact access. If a person does not know about the regulations regarding PrEP, they could choose a plan that might be more expensive because it says, PrEP is covered without any cost sharing. They could be pushed onto a higher tier plan, a gold rather than a silver plan. All of this is really impacting that access to and making sure that people have the right medication coverage for what is right for them. We also go into some policy recommendations in our report. There's some more details you can find there, but we really want state and federal policymakers to ensure that all these plans clearly and consistently reflect that all forms of PrEP are covered without cost sharing. We're asking insurers to update their formularies. And one thing is we also really want public health practitioners, public health departments, people who work in PrEP, educating community members about the PrEP regulations, and that if they have private insurance, their medication, their labs, their office visits must be covered without any cost sharing. So people should not get any bills after the fact. And I think we're getting closer to time, so maybe we can go back to this in our discussion, but there is some threats to USPSTF. There was a Supreme Court case in the last year about USPSTF. Overall, right now, USPSTF is still the name of the game. It is still, there, and the regulations are applicable to private insurance, but there's still some potential threats to USPSTF, but we can maybe go back to that in the discussion. Wanted to finally touch on a few things related to just federal funding for PrEP in general and some legislation. Coverage of PrEP is primarily through public and private insurance, whether that's Medicare, Medicaid, or private insurance. However, there are different federal funding programs that impact PrEP access and can help increase PrEP uptake. Primarily the CDC, there is the Division of HIV Prevention within the CDC that receives about $1.014 billion every year. It is the backbone of HIV prevention in the United States. Over 80% of that funding goes directly out the door to state and local health departments, community-based organizations. It does some of the core HIV prevention work like testing and some of the HIV prevention outreach that local health departments and CBOs do, but it also helps fund, PrEP navigation, outreach, testing, and linkage. So it's a really big part of, what PrEP is and access in the United States. A couple years ago, we did secure some funding for PrEP demonstration projects through the CDC. Those are ongoing. I think we're on our second year of funding for those PrEP demonstration projects. So there's a Project PRIVE, a Thrive. The idea of this is to sort of test real-world PrEP delivery models in health departments and clinics, really focused on communities most impacted. And then also a part of this funding, there has been some supplemental funding for the core public health HIV prevention grants. It was an add-on for EHE jurisdictions to accelerate PrEP access and uptake. And that funding has been ongoing as well. And then also outside of CDC, there is a program called the Ending the HIV Epidemic Initiative. If you're not familiar with this, this is an initiative that launched in 2019 that focused on 57 priority jurisdictions. So it's 48 counties, DC, San Juan, Puerto Rico, and then 7 states that have a lot of new HIV infections among rural populations. So those are fairly rural states in the South. The idea of EHE was to add on to the core public health work that CDC and the Ryan White program was doing and really increase funding to start reducing HIV infections in the most impacted jurisdictions. Part of that funding was $157 million that goes directly to community health centers. And this is specific on PrEP and PrEP delivery. CDC can't directly fund clinical services and they don't directly fund clinics, but community health centers do. Community health centers also have some of the closest impact to closest touch it points with the populations we're trying to serve. So that's another part of the federal funding for PrEP. And overall, there are still federal funding threats that we have for PrEP. Specifically, there have been over the last 2 years with the Trump administration proposals to completely eliminate HIV prevention funding at the CDC. That would eliminate that core public health response to HIV, as well as all of those services that are working to increase PrEP at community health centers and community-based organizations. We have been fairly successful over the last 2 years in fighting back against those proposed cuts. We've level funded CDC's HIV prevention over the last couple of years, but still seeing that the administration and Republicans specifically in the House want to cut that funding is really shocking and doesn't really comply with what the previous Trump administration had done with expanding HIV prevention with the HE initiative. Also, as funds are appropriated, even if we get that funding out the door, there's been a lot of threats to just federal funding in general that has occurred over the last 2 years. So we've seen CDC grants have been slow walked, they've been threatened to be withheld. There is a new potential rule that has come out from OMB that can cause further disruptions in how funding is sent out the door. And then Mike mentioned Medicaid restructuring. I won't go into details because he covered that pretty well, but as folks lose Medicaid coverage, they also lose those access to the no-cost PrEP that they get under Medicaid, especially in expansion states. And finally, wanted to just touch on three bills in Congress that are specific on PrEP. They all have different routes, but they all have the goal of expanding PrEP access. And unfortunately, they all have pretty similar names, so they're a little bit confusing to keep track of. But the first is the PrEP Assistance Program Act. This is from Representative Bonnie Watson Coleman from New Jersey, who is a huge champion of HIV and PrEP in Congress. Creates a $400 million a year grant to CDC grantees, and it would create sort of a PrEP pass, which is a direct federal reimbursement for PrEP drugs and labs. So the idea is someone could get they would get a sort of a copay card, if you're familiar with that, which would create direct reimbursement for PrEP drugs and those labs. The PrEP Access Act, this is by Representative Pocan out of Wisconsin, who's the chair of the HIV/AIDS caucus. This really works on expanding providers. So it would add pharmacist-provided HIV prevention services to Medicare Part D. There have been a handful of states who have tried to increase access to PrEP through pharmacists. So directly, you can go to a pharmacist rather than a doctor to access PrEP. So this would be a federal expansion of that. And then the PrEP Access and Coverage Act, which is something that has been introduced by Senators Schiff and Smith, Schiff from California and Smith from Minnesota, would really mandate coverage. So it would require all payers, private, Medicare, Medicaid, VA, the Indian Health Service, they would cover PrEP and PEP without any cost sharing or prior authorization. These are pieces of legislation too. They're not going anywhere in this Congress. Not much is going anywhere in this Congress, but as we're looking to next year and the potential of changes to leadership and which party controls Congress, thinking about how these pieces of legislation are going to be pushed in future Congresses is something to pay attention to. So I think that's the last slide. I'll stop sharing my screen if I can figure that out. Okay, there we go. Awesome.
Great. Thank you so much, Mike and Nick. That was a pretty comprehensive presentation. Thank you so much for your time and for sharing your expertise with us. Now, again, I would like to encourage the audience to make sure that you use the Q&A box or the chat to ask questions to any of the panelists. But before that, I would like to pass it over to Tevin and Dexter to share any initial thoughts, anything that caught your attention, or anything that you have seen within the communities that you represent in terms of actions needed.
Yes, thank you, Damian, and thank you, Nick and Mike, for that amazing presentation. I took all the notes and just had so many things to learn along the way. So some initial thoughts are, I did not know about the grade A rankings that then allow for, expansion of policy specifically with clinician requirements as well as private plan coverage. But then also about the state performances that you talked about in your report and the reality of how that gets implemented. One question that I did have was about with that grade A ranking and specifically with those clinician requirements, providing the service, providing PrEP, One thing that I've just experienced in my own personal experiences when talking to providers about how I am on PrEP, how I've been on PrEP, there's a lot of providers that do not know what PrEP is. That seems to be a consistent issue that I've encountered, but also heard about through people who are also on PrEP. And not only the clinicians not knowing about PrEP, but also discouraging certain populations from being on PrEP. I've heard about Black women, heterosexual Black women, seeking the service and being told that they don't meet the criteria to be taking PrEP. And so, given this ranking and given this requirement for clinicians, I was curious about what y'all's recommendations are, or has there been progress that you've been seeing more on a policy level to really hold clinicians accountable, those specific clinicians who are not aware of PrEP, so that they can continue encouraging and prescribing it for folks?
Yeah, that's a wonderful question, and it's an issue we've been dealing with since PrEP first came on the scene. One thing that the USPSTF recommendation is helpful with is they're educating clinicians on this. I will say they actually update these recommendations. So there has been an update for PrEP. I forget when that update was. Mike might know, but previously the recommendations had some pretty specific criteria. Someone is has had a STI, or they have reported unprotected sex with a certain amount of partners. The most recent update to the USPSTF recommendation actually included providing PrEP to people who request it. So rather than going through those clinical details of saying, well, you don't actually qualify for this because you haven't had a STI, or you aren't having multiple sexual partners, those can change easily. Pointing to that as one of the clinical considerations that a doctor might have is really important. And if folks are running into an issue where they're saying, their doctors are saying, we don't think this is right for you, being able to point to that is something that's really important. I would also say, if your doctor doesn't say that you should be on PrEP, but you want to be on PrEP, then there's a lot of different options in terms of telehealth and the different tele-PrEP providers in the United States that can provide that, because there's folks who might not want to ask for PrEP from their primary care provider because there's still stigma there. So having that grade A recommendation hopefully is something, but provider education is still something that needs to occur, and part of the discussions. And I think there has been, when we're talking about those PrEP pilots that CDC has been doing, they're looking at that provider education and how they get that information out.
I would just add, and I'll put it in the chat. We produced a PrEP billing guide that particularly for individuals, would be for individuals who have private insurance. For the most part, but it can help those individuals that are still getting bills, or maybe their provider just doesn't know how to bill the health insurance company, to make sure that they don't have any cost sharing, that they have their labs, their doctor visits are all covered. There's a new ICD-10 code that was developed to make it so that it can be more encompassing of all of the services that are provided for PrEP. And so it can be something that is useful both for providers, for case managers, as they're trying to help their clients and their patients navigate private health insurance, which is not necessarily the easiest thing for folks to navigate.
Perfect. Thank you all so much for that.
Thank you again. Oh, sorry. Oh.
You can go ahead.
I was gonna say thank you again for sharing, and Damian for having us, Nick and Mike. It was actually really helpful hearing about the grading scale, because I also I work in this field, and I work at an agency that's Part A funded, but I have a history in PrEP. my medication was recently not covered by my formulary until like last year. So originally, I actually had to go through my clinic's 340B pharmacy, and they had to do that because they really weren't sure. And even now, I'm still having difficulties. Like, I am still on the pills because I don't meet the prior authorization, and it's been a bit much. So to see that information versus to see how that adjustment is, there is still a bit of lagging on this side. I am from Virginia, so I am from a military town. One of the big things for us is TRICARE. TRICARE is the number one. I've had a couple of individuals that I watched engage in PrEP, and then because they were active duty, had other things that occurred, so they discontinued. And then by the time they came back into care with me, they needed to go and be submitted for Ryan White services. And so I appreciate you sharing that there is legislation right now to address those other concerns. Because for us, being TRICARE, we're a military town. When we're looking at, like Tevin mentioned, some of those qualifying factors, we don't like the idea that you have to wait for an STI result to come back positive before you get care. I know for us, for individuals who are engaging with sexual play with other individuals, we have a lot of transient people. We have a lot of people coming in and out of our area. I'm out of Norfolk, so I have 4 different military bases in my area. Folks will leave base to pay for this care because in the military, yes, there's HIPAA, but it seems to be a suggestion for them. So at the end of the day, more people are aware of your care. So I think that for me, what was a really good takeaway was seeing that there are policy and initiatives that are being pushed to gather this other demographic of individuals, because I know for many of them, if you're already worrying, given all things considered right now, about your identity when you show up, I've had individuals tell me that the reason their doctor said no was because they were married. And that's a whole other series of culture differences that, from navigation standpoint, we are not coached to address because it's not their desire. It's more so their employer's desire. But one of the things I guess I'm interested in is, for those of us who are on the call and who are listening, what are some things or some steps or some actions that we can take to either educate people about these policies that are coming up, or to even be the advocates? I know that I have a few agencies that go to the Hill, and we did not know these things when we did this a few months ago at the Hill. And even though I'm a Part A provider, I still refer out for those because I would prefer them to be on PrEP. So if there was just a way that we could either do some internal localized capacity building, or if there is something that we can do to kind of mobilize so that there is a voice, because right now the voice is those of us who work in the field. And this, as they say, this is a human condition. HIV does not have a face. So I want to get more allies involved so that way they can mention. I think for me, it's realizing we have a lot of a giant caregiver community. So there's a lot of folks who are taking care of individuals living with HIV, and they don't always see themselves in this as to what PrEP means for them. So I just want to make sure that they're made aware as well. So do you have any suggestions on how we can just share the knowledge and share the wealth?
I think the work that happens on the ground really is the most important piece to all of this. The leaning into our communities to make sure that they are aware of what their options are, and when it comes to accessing PrEP, but not only what their options are, but what they can do when they face the barriers of their providers not doing it, or they're not prescribing it, or their insurance coverage is giving them, their insurance company is giving them the runaround and not wanting to cover all the services that they need. I don't think there's a one solution for that education. I think that everyone ends up playing a role, whether it's through their church, whether it's through their friend groups, whether it's through the ballroom community, whether it's through a CBO or ASO within a community. It all has some sort of role and making sure that the community is educated about what their options are, whether it's their PrEP options, but what their options are if they are denied the services, or if their provider doesn't want to prescribe it. I'm from a very rural community in North Carolina that my own local health department will not prescribe PrEP to individuals. and trying to, I have an aunt who works at the health department, as normal for most folks living in a very small rural community. And I have tried to have the conversations with her to be like, this is what you can do to try and persuade your medical director or your whoever is the decision maker within your entity to make sure that the services that the people are coming in to get, they're actually able to access those services. And it's not something that happens through one conversation often. It's something that the drum has to be beat over and over and over again in order for them to see it. And it's also realizing that 340B maybe is the thing that switches that conversation up, or there's some sort of mechanism to bring in more resources to the entity because they're going to start able to providing PrEP. And so trying to figure out how to message it to those decision makers, I think can be an important piece of that.
Yeah, I think what Mike said is great. I would also like to add, the HIV, people living with HIV have a really strong voice and a really strong history in advocacy. People using PrEP might not necessarily have such a strong voice in the advocacy field. So one thing I would point out there, the PrEP for All, which is a great organization focused on PrEP, they have a PrEP users union. So the idea of this is for folks who use PrEP, they can be a part of this, that they share stories, do advocacy work there, sort of putting a name and face behind what people look like who use PrEP, because it might not be who you think it is. So I'd encourage folks to look up that if they're a PrEP user. And also just naming and shaming is something that the HIV community does really well. Before the USPSTF recommendations, we had a lot of companies that wouldn't cover PrEP for their employers, and that we had to do public campaigns saying, hey, you aren't covering this medication. If you have an insurance provider that's they're charging you for the medication or the labs, connect with me, connect with Mike. I'm sure we'll share our emails and we can help you do some of that, reaching out to state regulators so that they know, this insurance provider is not actually complying with the rules. There's a lot of recourse there.
Yeah, I was actually going to suggest if you can put your emails on the chat so that everyone can, because I know that we are close to time, so just making sure that this is a very rich conversation, and just to provide the opportunity for folks that would like to engage with you. There are 5 questions on the Q&A box that I wanted to bring up quickly. The first one is for Mike, and it's regarding to the piece that you were presenting. You mentioned 18 programs, and the question is if those 18 programs were state or regional programs.
None of them are regional. They're the majority of them are state programs, I think, with the exception of 3 that are county and or city programs.
Okay, thank you. And we have a question from Cesar Velasquez. Do you have any recommendations about how to ask insurance companies for clarification about coverage for STI testing and PrEP?
Yeah, unfortunately, it ranges, all different insurance companies. They don't have a centralized, thing where they describe all of this. The quickest way is to call them, state, what, ask them, I want to know what is covered for PrEP, what the copay will be for STIs for PrEP. Unfortunately, it's just calling and trying to get information out of the black hole that is, insurance companies.
And I had a question regarding around that, Nick, because as you were presenting, you mentioned that 12 insurers had you graded A, and I was wondering if there was any type of advocacy surrounding those, or did it just happen because they are reformed? I was just curious to see that.
Yeah, we've been doing this report for the last 3 years. Every time we do it, we send it out to insurance regulators. So we've had actually states who have created bulletins. So the insurance regulators will send a bulletin to all insurance plans in their state that they regulate, and they will state, hey, you need to say X, Y, Z in your plan documents. You need to cover X, Y, and Z in that. If you look in our report, we have some examples of some of the states of what they've done, but it's been a lot through the insurance regulators, and also we've been, Mike and I have done some work with some of the AHIP, which is the American Health Insurance Plan, the groups that represent insurance plans. We did a convening a couple of years ago about this. So unfortunately, it's not across the board great, but getting with insurance regulators at a state level has been something that we found to be pretty useful.
And I just put a template letter. I will say the template letter is currently being updated. And so the link will likely stay the same, but it is a letter that NASDAQ, in partnership with some other organizations, put together that folks, whether it's the provider or the patient, can use to send to their insurance company around any cost sharing that they are having for PrEP when they should not be having that cost sharing.
And there's also another question for Nick. Do you have any insight into whether plans can apply utilization management tools like prior authorizations, step therapy to PrEP products to steer patients towards certain options or control which PrEP medications are covered?
Yeah, in private insurance, the regulations say that they should not be doing that. With PrEP, step therapy is not applicable. Step therapy means someone takes a medication and it fails. If they take PrEP and it fails, that means they have contracted HIV. So doing that is logically doesn't make sense. They should not be doing, step therapy and utilization management, especially for oral PrEP, because long-acting injectables are fairly new. We've seen insurance companies that are having them do oral PrEP first, but that's something that's as these regulations are trying to be enforced, we're making sure that that doesn't happen.
And also, as we close this webinar, I wanted to bring Tevin and Dexter, because you are leaders from the community. You have been doing advocacy for quite some time. So I think it's also to bring back that conversation about what action or how action looks like from within the community. Because I think that if there's something that we can gather from today's conversation is that policy has so many levels, right? It can be state, it can be national, it can be with the insurers, it can be with the doctors, with the patients. So from your expertise from your perspective, how would you encourage your community members to take action, or how action would look like in your specific context and also as gay men of color?
You want to go, Dexter? Even I see you. Um, I would say that specifically, well, one, educating ourselves is incredibly important on this, right? So almost like a train the trainer framework there. But also understanding that how do we utilize our lived experiences and then connect those within our own respective communities. And so I do think that overall education is super important there, but also understanding, what are our own resources available. So I'm operating in the context of Tennessee and Middle Tennessee. I'm sure you all know about a lot of those restrictive policies in place within the state, but there are also a lot of incredible organizations doing that boots on the ground effort. Mike, I will say what you mentioned earlier about how the assistance programs should serve best as a complement to a strong public health system instead of the substitute. And so that really resonated with me because I also think about not only do we empower our community members, but how do we empower our fellow colleagues in the workforce to really support the fractured system that we have in place. And so I think about now moving forward, what does training look like for my team members? How do we all become on the same page? I work specifically on the case management side, so supporting folks living with HIV. So what does prevention look like in that capacity at the same time, right? I also think about specifically, I'm a global health practitioner, and so I think about global health models and frameworks that I feel like domestically we tend to ignore. We tend to look at models within other states, which are helpful and necessary, but there's also incredible work happening beyond our own borders. And so I think about how, as case managers, as we are inherently community health workers. So what does that look like to use that framework, especially in rural contexts, which is where I work within a lot in Tennessee. And so looking at, with this education that we have, with the resources that we have, how can we then train ourselves to then train our client or educate our clients with the same resources available?
I love the way, I always love your voice. Um, I will say for me, this is a beautiful opportunity to take the access that I learned. The thing that kept coming up in my mind during this conversation was where were the gaps in advertising? Because the agencies back home for me are not here. I sent a lot of other people. There are other folks who came, but I think I consider myself an academic conversationalist. I very much enjoy this element, but many people need the language to match their level of understanding. So I think for me, it is this beautiful opportunity as a gay man of color to have access to these spaces, but more importantly, to bring this access back home to get more people involved. I'm just one example of a face. I love storytelling. I love very non-traditional, innovative ways to do outreach. So this type of information for me is going to get wrapped into some of the other things that I do back home. I do a line dance history project, and I was debating adding a policy component to that. But calls like this let me know this would be a great opportunity to integrate this into some of my other outreach. I'm also going back to school, and I'm going back to an HBCU. So I'll have an opportunity to work with others in the master's level capacity to be able to integrate this. I work with interns. So one of my main goals is every intern series that I've had about 38 interns so far. We go through an HIV education series, but I've never really gone too deep into PrEP. It's just a part of their series. But this kind of information lets me know there is some opportunity for you all. This is great intern work that I can add because I want an intergenerational approach. I really want the next generation that's going to be disproportionately affected by this to be introduced now before it becomes the same epidemic that we survived through the first time. So I just appreciate opportunities like this, and my call to action to those in the chat is tell at least one person that you know that's not in your field about this and see where it goes because it will snowball.
Great. That's definitely a great starting point. So thank you so much, Tevin and Dexter, because you really honed in into self-education, educating peers, and also how to integrate academia. Dexter, I know that you also integrate art within the work that you do. So really thinking about creative ways to educate the community. And I apologize for folks that we weren't able to answer your questions. You have in the chat the email for each of our panelists if you want to continue with this conversation. And again, thank you, Nick. Thank you, Mike. Thank you, Tavin. Thank you, Dexter, for your time and for this really, really rich conversation that I hope that we get to continue in the future because there's definitely a lot to cover and I would like to see that happening. Thank you all so much.
Thank you.
Thanks.
Thank you. Bye, folks.
Thank you. Thank you all.
Thank you. Bye.